Welcome back, everyone, to part 31 of our series. Today's explainer is all about the fundamental divide in medical billing between professional and facility environments. If you've been following along with us that the healthcare revenue cycle can get pretty intricate, well, today we're going to break down the walls between these two very distinct billing worlds. Let's get right into it.
Here is our roadmap for today. We'll start with the big picture split between professional and facility billing. Then, we'll look at the specific claim forms you're working with every single day, namely the CMS 1500 and the UB-04. After that, we'll unpack hospital reimbursement risk with DRGs. And finally, we'll wrap up with the coding building blocks, like HCPCS and revenue codes.
Okay, let's kick things off with Section 1, Professional versus Facility Billing.
To really understand revenue cycle management, you have to think of your professional identity as a crucial translator. It's like a giant puzzle. While a medical coder takes complex medical processes and converts them into standard codes, you, the biller, take those codes and actually build the financial report. You're the vital bridge connecting the patients, the providers, and the insurance companies. You're the one making sure healthcare practitioners actually get paid for their hard work. And honestly, if that translation fails, the whole system just breaks down.
Now, there is a strict regulatory wall between these two environments. On one side, you've got physician coding. This represents the doctor's specific job, and it's used in outpatient settings. Think private offices or ambulatory surgical centers. On the flip side, facility coding is all about the hospital. It's specifically focused on the inpatient environment. These two worlds have completely unique billing requirements, and as a biller, you absolutely cannot mix them up. The resources a patient consumes in a quick outpatient clinic visit are drastically different from what they'd use in a hospital ICU, right? The coding literally has to reflect that reality perfectly.
Let's move on to Section 2, the CMS 1500 claim form.
So, when a physician does their work in an office or an outpatient clinic, this is exactly the form they use to submit their procedures. The CMS 1500, which you might actually still hear called the HCFA 1500 by some folks, is the absolute cornerstone document for clinical practitioners filing claims for professional outpatient services. It's basically the official language of the doctor's office.
You can really break the CMS 1500 down into three distinct chunks. Section 1 captures the patient's registration info, so getting those demographics and insurance details 100% accurate. Section 2 details the actual procedures performed, and Section 3 covers the diagnoses. Now, here is the secret to a clean claim. The procedures in Section 2 absolutely must be justified by the medical necessity of the diagnoses in Section 3. If a doctor orders a pricey MRI in Section 2, that diagnosis in Section 3 better explain exactly why it was medically necessary. Otherwise, bam, denied instantly.
All right, pivoting away from the doctor's office, let's look at Section 3, the UB-04 claim form.
84. That is the exact number of individual boxes required on the UB-04 claim form. Just think about that for a second. Within those 84 fields, you are packing in highly specific data points that are totally unique to facilities. For example, you have to include a type of bill or TOB code, which tells the payer exactly what kind of facility it is and the frequency of the bill. You also have to carefully distinguish between the admitting diagnosis, so the symptom that actually brought them through the hospital doors, and the principal diagnosis, which is the ultimate primary reason determined for their stay after study. Processing just one of these claims means making sure all of this incredibly precise data lines up perfectly.
The UB-04, also known as the CMS 1450, is the heavyweight champion of facility billing. To capture the massive overhead of a hospital, you rely on a huge database called the Charge Description Master, or the CDM. Think of the CDM as the hospital's giant menu of every single billable item. So, when a nurse grabs a bandage or a surgical suite is booked, the CDM links that item to a 4-digit revenue code. These revenue codes, along with condition and occurrence codes that report specific events related to the bill, are what populate the UB-04. That's how we categorize room, board, pharmacy, and equipment. You're not just billing for the doctor's time anymore. You are tracking literally every resource consumed in that hospital.
So as a sort of mental filing cabinet, you need to permanently separate these two. The CMS 1500 is your go-to for professional outpatient services, using CPT codes for what the physician did. The UB-04, on the other hand, is for institutional facilities. It captures the massive cost of inpatient care using those 4-digit revenue codes mapped from the CDM, all within that highly structured 84-box format. Mixing up the intent of these two forms is a surefire way to derail the entire revenue cycle.
Moving right along, here is Section 4, Understanding DRGs and Risk.
Now, how do hospitals actually get paid for admitting really sick patients? That's where DRGs, or diagnosis-related groups, come into play. The inpatient prospective payment system packages the entire hospital stay into a single, fixed case mix rate based on the principal diagnosis, rather than paying for every single bandage and IV drip line by line. But modern billing uses MS-DRGs, Medicare Severity DRGs. This means payment isn't just based on the core illness, but how severe it is. The reimbursement rate shifts dramatically based on the length of stay and whether the patient has complications or major comorbidities, what we call CCs and MCCs. So a patient with pneumonia who also has severe uncontrolled diabetes, which is an MCC, will yield a higher weighted MS-DRG than a patient with just pneumonia alone because their care simply demands a lot more hospital resources.
The whole compensation cycle relies entirely on capturing that risk accurately. First, you identify the admitting diagnosis. Second, you assess the degree of patient risk and illness. Third, payers like Medicare adjust the reimbursement based on that specific risk level. The fundamental rule here: the sicker the patient, captured through those CCs and MCCs, the higher the compensation the hospital receives. It makes perfect sense, right? It ensures the facility is appropriately funded for the massive resources used to treat their most critically ill patients.
And just to add another layer, within this inpatient DRG system, coders rely on ICD-10 PCs for hospital procedures, which is completely distinct from the clinical modification codes we use for general diagnoses. ICD-10 CM is used universally to code the diagnosis, the why the patient is there. But ICD-10 PCS is strictly utilized for reporting inpatient hospital procedures, the what was actually done to them while admitted. Just remember, you are never going to use a PCS code in a standard outpatient clinic.
Almost at the finish line, Section 5, HCPCS and Revenue Codes.
The HCPCS coding system operates in 3 tiers to make sure everything from a basic physician visit to a highly specific hospital pharmacy item is perfectly categorized. Level 1 gives us the standard 5-digit CPT codes for medical treatments. Level 2 introduces 4-character alphanumeric codes for all the stuff CPT codes miss, like physical goods, pharmacy, and non-CPT services. And Level 3 features 5-character codes starting with W, X, Y, or Z for unique local definitions. And here is a really crucial point about how these work in an outpatient facility setting. Under the Outpatient Prospective Payment System, or OPPS, these CPT and HCPS codes are grouped into Ambulatory Payment Classifications, or APCs. So just like DRGs package inpatient care, APCs group outpatient encounters into fee schedule categories using status indicators.
So what does this all mean? As a biller, are you merely submitting paperwork? Or are you the vital translator ensuring a facility is fairly compensated for the life-saving risk it assumes? Well, I hope the answer is obvious. You are definitely not just pushing paper. By mastering both the professional and facility ecosystems, you're ensuring providers never leave hard-earned money on the table. Thank you so much for joining this explainer. Please like, share, and subscribe to Decode Healthcare with our Shaw.